Diagnosis and treatment planning for RPD candidate classification. So first of all, let's talk about what's the indication and contraindication for removable partial dentures. So the indication for removable partial dentures first is when you are not able to do a fixed partial dentures over the patient. Sometimes we have a long span missing tooth area is not good for the FPD's design, or we have a distal extension situations, which means that you are not able to find abutment tooth on the posterior. Also, sometimes after the extractions, we may need a temporary or interim removable partial dentures to just fill the space before we do a fixed partial dentures. They also be options. Sometimes when the edentulous area is crossed arch, you need to stabilize both sides together. That's also an indication for the removable partial denture. The last one is sometimes when patient is not available to pay too much treatment fees to restore multiple edentulous area, this removable partial denture options will be the best option for the patient. So what's the benefit of the removable partial dentures? The first, this is the good option to most edentulous cases. I would say maybe over 90 to 95% of the edentulous areas cases can do the removable partial dentures. The second, this is a good option to preserve the sound tooth structure, because when we need to do a fixed partial dentures, then we have to prep the tooth. It also affects our tooth structure's continuity. The third is economic consideration. Compared to the fixed partial dentures or implant restorations, the removable partial dentures is a cheaper option. The second is easily to do some modification if you design well. For example, if you have some tooth is questionable or guarded prognosis, maybe it's not a good candidate to do a fixed partial denture. However, if you design your framework well, you might still have a chance to use those questionable or guarded prognosis of tooth. And in some circumstances, when patient lost more teeth in the future, some design of the removable partial denture allow you to add the tooth on the existing removable partial dentures. Means that patient can still use the existing removable partial dentures for a longer time. But what's the contraindications for removable partial dentures? First, aesthetically. Remember, we have to have the metal framework for the removable partial dentures. So when patients smile, you definitely can see the metal components around the tooth. The second is the poor oral hygiene. When patients is not able to clean the tooth very well, have a periodontal disease or the caries, then this is not a good candidate for removable partial dentures. The third will be lack of a tooth to provide suitable retention of removable partial dentures. Remember I said almost 90 to 95% edentulous area cases can do a removable partial dentures. However, if patient lost too many tooth, then you might not be able to design a proper framework for the removable partial dentures. And some patients, when they get older or they have some disease like Parkinson's disease, they don't have good physical control. They are not able to sit or remove the framework out of the mouth. Then that's a contraindication to this treatment option. And the last one will be the patients with improper expectations. When patients think about a removable partial denture in the first time, they also think that those clasps around the tooth is kind of like provided fixed fillings for them. However, we know that this removable partial denture is still removable. So those clasps will not exactly provide those fixed feelings. Diagnosis. So we should know patient chief complaint, what's patient's medical and dental history, and how's the relationship between the doctor and the patient, then also evaluate the psychosocial factors. If patients have existing dentures, always remember to examine the patient's existing partial dentures first and interview them about how its comfort function aesthetically. Remember, patients already have a history of wearing a partial denture. However, he or she come into the clinic to seek for a new options or a new treatment plan. So you should know what's going on for the reason one and how you can think about if you can improve that, or maybe you should lower the patient expectations. So just remember, treat patient carefully. You haven't earned their trust yet, and you need to be tactful. Then the second step is to try to do the extraoral and intraoral examination. When we do extraoral examinations, then you have to check those following factors. Also need to be very careful about occlusal vertical dimensions. When patients lost their occlusal vertical dimensions, that will be a pretty hard cases if you want to restore it back. For intraoral examinations, you definitely just not only look on the tooth, you also need to check the soft tissue, edentulous ridge, tooth by tooth. Also need to check the interarch distance because some patients have limited interarch distance, may not able to fit the framework and the denture teeth. Also need to check the maxillomandibular relationship. The other important step is the level of oral hygiene. Remember, when patients wear the removable partial dentures, then the framework is over the tooth. If patient doesn't have a good oral hygiene, that means that those abutment tooths may be easier to lose in the future, and you need to plan that ahead. Some patients maybe have some medications or disease, then will affect the quality and quantity of the saliva, and it also will affect the tooth condition. You also need to notice about the soft tissue part, especially when you want to design the removable partial dentures. You have to be notified where is the muscle and frenulum attachment, will they affect your framework seating, and how's the vestibular depth and undercuts, which you won't want to engage too much, so patient will feel discomfort in the future. Also, some patients maybe have some bony exostosis or the mandibular torides that will affect your framework design. After soft tissues evaluations, then we will move to the tooth diagnosis. So first, you should notice what's the number and the position of the remaining teeth. Is any teeth have active caries, and how's the restorabilities for those specific area. And if patients have existing restoration, you also need to notify and to see if that will affect your removable partial dental framework design. Some patients might have a teeth have a hypersensitivities or mobilities. You also need to be notified. When we talk about to use abutment tools, ideally that will be just only have class 1 mobilities is available for most of the cases. However, in the clinic, it might have some flexibilities of the tooth selections, but that will be case by case. The other important thing is to check the plan of occlusions, because when patient lost a tooth for a long time, then the tooth was super erupted and might affect your tooth occlusal plan setting, and also will affect the articulations. You also need to be very careful for the periodontal status for the tooth, especially when you select the abutment teeth. Also, some patients' tooth might have a severe bone loss, vacation involvement, mobilities, even like occlusal traumas. Those will also need to be found out and be solved before you started the treatment of the removable partial denture case. You also need to check about occlusions and articulations to see if patient have parafunction habit, will give the extra forces to the tooth to cause the periodontal disease or even the bone destructions. If patient have any histories about the prosthesis failure or the poor tissue tolerance, then you might need to find out what's going on and how you can prevent it happens again. And when we do a diagnosis, we definitely will need some extra tools to help us to do a diagnosis. The first is the radiographs. You definitely will need a complete mouth periapical films, the PA films, for each of the tubes. Sometimes when the ridge have a severe resulted, you might also want to take a panoramics, the panoramic x-rays that can help you determine how's the remaining ridge size. You also need a diagnostic cast. Remember, when you have a diagnostic cast, it should always be mounted on articulator because that will make us easier to evaluate multiple factors we will explain later. And this diagnostic cast also can provide you to do the treatment plan presentations, the pre-treatment plan record, help you to fabricate a custom impression tray, and also to do a diagnostic wax-up if you need it. So remember, not just only take the x-ray, you also need to take the diagnostic cast and mounting on the articulator. Sometimes we might also want to use some photographs to record the existing conditions and get a reference in the future. The last one will need to do the preliminary design of the removable partial dentures. So when we have x-rays, we want to check if we have any active caries, how the periodontal conditions, crown root ratios, and is patient have any pathologies will affect our removable partial denture design. And a diagnostic mounting is always required for removable partial dentures diagnosis procedure. It is needed for reference to design a framework which not interfere with the patient's intercuspitations or the vertical dimensions occlusions. So when you do a diagnostic mounting, first of all, you need to use arginate to take preliminary impression, pull out the diagnostic cast, and then to do a FACEBOW and interocclusal registration, then to mount on the articulator. And when we do a diagnostic mounting for the partial dentures patients, we need to use semi-adjustable articulator. We need to FACEBOW transfer for the maxillary cast, mounting mandibular cast in the intercuspitations, which is called ICP location. And we will also need to use a record base in most of the cases. However, if you can hand articulating the upper lower cast accurately, you might not really necessary to use that. But in most of the cases, especially in the distal extension cases, you definitely will need a record base. So here, record base are always necessary when posterior teeth are mixing, because those record base can help to support the diagnosis and master cast during the mounting procedure. So think about you already finished those procedures in the sim lab simulation cases, which you have one side have a distal extensions edentulous area. That's a reason why you need to use a record base to take a vibration. And when you finish your diagnostic mounting, you have to determine the accuracy. So you have to use two ways to check. The first is how's the tooth contact in ICP on the mounting cast compared to the patient intraoral condition. The second is about the space between the edentulous ridge. Sometimes we might have the same tooth contact in ICP. However, when you use a base plate occlusal ring to take the bifurcations, it might floating, so the space between the edentulous area on the cast is different from the intraoral condition. Then you will need to redo the bifurcation record again. So what's the reasons for diagnostics mounting? Because first, it can give us to determine the favorable tooth condition, the contour and inclination might affect our removable partial dentures design. Also, we can check the unfavorable bony and soft tissue contour or the occlusions. When we talk about the occlusions, not just only to think about the tooth contact, you also need to think about what's the occlusal plans properly, because when patient lost a tooth, the opposing tooth may erupt it and affect the proper occlusal plan. Also need to check if any teeth need to do any occlusal adjustments to prevent those occlusal traumas. The last one is to check the intra-arch distance. When sometimes when patient lost a tooth, those upper or lower jawbone will compensate and get enlarged, may give you a limited intra-arch distance that you are not able to design the removable partial denture properly. So let's take a look for this case. So what's this case tell you? This case tell you that in the first beginning, the student didn't notice that this tooth over-erupted over the molar. So it creates the uneven occlusal plan. Also get limited intra-arch space on the mandible. Eventually, when you start to separate teeth, you can find out you will have a huge occlusal interference. So the framework may be able to fit well with the tooth, but when you separate teeth, that's not workable. So what's a proper intra-arch space for the removable partial dentures? So think about that first. For removable partial dentures actually includes three different parts. On the bottom is your metal framework, and on top of it, that's a denture-based material. And then you separate denture teeth on top of it. So first of all, think about the metal framework. The metal framework used to have 1 to 2 millimeters thickness, or even more. The denture-based material should at least have 2 to 3 millimeters to get a good support and stability. And when you set up a denture teeth, when you measure those denture teeth type, it used to be have to 6 to 8 millimeters on the posterior teeth. So if you don't change anything, everything go for ideally, actually you need at least 9 to 13 millimeters for single arch RPD. However, you might able to do some minimum requirement. At this, the metal framework could be like 1 millimeters, denture base could be 1 millimeters, denture teeth may be able to adjust it about 5 millimeters for static reason. So minimum will be around 7 to 8 millimeters. But here you have to know, if your patients already have intra-arch space just fall into the minimum requirements, that means that those aesthetic or functionally will be affected. That's not the ideal situation. And if your patients have less than 7 millimeters intra-arch distance, it definitely is not the case for removable partial dentures. So when we do a diagnostics mountains, that we actually have 5 steps, which you already practice in the sim lab. So first is to verify the record-based fit and stabilities. So the record base should not bind or rock over a ridge, and also need to be fit passively. And you have to check for the interference when close the mouth into the ICP locations. You have to check each base separately and then check them together. If you change patients intercuspitations relationship means that you change patients occlusions, which is not allowed when you do a removable partial denture cases. And you have to check that patient's teeth only touched when you check the ICP contact. Then you have to verify the tooth contact with the base is no different than without them. After that, you will do a FACEBOW transfer. So we already mentioned that in the SYNLAB. So you have to use a bifork with the base plate wax to take the bifurcations over the upper. And you have to notice that midlines should be fit well on the bifork marker. And then you will do a FACEBOW transfers, which will need to use the ear hole and involvitals notch as a reference point when you use your FACEBOW transfer record. And then you have to know how to assemble those and then transfer back to the articulator, which we already mentioned in the SYNLAB. And then you need to take the maxillomandibular relationship. So you have to verify those teeth contact and make sure that your waxing doesn't have any interference, and then take the bifurcation. After you got the FACEBOW transfer record, then you can mount the maxillary cast. Use the FACEBOW transfer record. And you also need to know how to do the setup. We already mentioned that in the SYNLAB. If you have any question about how to use this, then you also can check the SYNLAB videos on the Blackboard. I just want to remind you, when you do a FACEBOW transfer setup, before you do a mounting, you have to be careful to check those intraorbital pointer and the support. The relationship should be the same as you saw on the pictures. And the anterior support for the FACEBOW also need to be the same as you saw on the pictures. After you finish the upper cast mounting, then you will do the lower mandibular cast mounting, followed by your bifurcation record. So the other important things when you do a diagnosis is to check the patient's factors. You have to see how the patient's modifications, how the attitude, and how the home cares. They will also affect the success of the removable partial dentures after you deliver it. So patient definitely will need to have acceptable emotional and physical health. So you have to check the basic health observations to get the complete health histories. Also, patients have to have general physical and mental capacity to tolerate a prosthesis. If patients have a previous prosthesis and doesn't like it, you have to find out what's going on and try to see if you can improve that. Also, some patients might have physical handicaps issues, so it's not easier to control the hand, and so they are not able to sit or remove the removable partial dentures. Then you have to think about if this is a good case to do a removable prosthesis, or you need to go for the fixed options. And I would also like you to notice the patient modifications. Sometimes when patients want to have a new prosthesis, they might have a different feeling or different expectations from you. So you have to know what's the difference between you and the patient and try to make sure you can balance both together. Also, even if you do a diagnosis and a treatment plan very well, you do your treatments well and deliver good removable partial dentures. However, the care of the partial dentures is also very important. So you have to educate your patient to know that actually the patient and the dentist share the both responsibilities for the success of removable partial dentures. If a patient couldn't keep the proper oral hygiene or regular maintenance recall appointment with you, then maybe in the first beginning the removable partial denture can be succeed, but you are easier to fail in the short term. And remember that this patient education should begin at the initial appointment and continue throughout the treatment. I would say sometimes when we have a failure cases, maybe it's not from our design or treatment, it's from the patient. So that's very important for you to remember that the patient education is pretty important throughout the whole treatment. So let's talk about the treatment planning procedure. So this flow chart talk about what's a treatment sequence. First of all, we do a diagnostic and treatment planning. Then we do a surveying, tripoding, and the design, which already you practice in the sim lab. Then we will do a mouse preparation, final impression, framework try-in, and to set up and deliver the partial. So the phase 1 treatment actually is to do a diagnosis, treatment plan, and the design of the cast. And when you started to do the case, that will be the phase 2. So when we do a treatment planning, we have to collect all the clinical data and to consider all the options. So that's very important when you do a diagnosis and treatment planning. So the treatment planning in the phase 1 is included the preliminary survey and RPD design. And then you have to develop the treatment plan for the patient. Also, if a patient have any active disease, then you have to do a disease control in the phase 1. It might include surgical, also, or restorative procedures. When you finish the disease control, all the teeth is in the health condition, then you move to the phase 2 to do a definitive or permanent treatment. So the first step in the phase 1 is to try to get a preliminary survey and RPD design. This preliminary survey is what we call the diagnostic surveying in the sim lab. So when you finish the diagnostic surveying, then you will come out a possible RPD design, which will include the type of major connector, the type of denture base, which area you need to replace with the tooth, where is the location of indirect retainer, and where is the direct retainers, where is the undercut, and what type of a direct retainer you're going to use. Remember, in the school, then all RPD cases, this preliminary surveying and RPD design form need to be approved by the faculty before any treatment started. When you comes up the preliminary survey and design form finished, then you will know what's the treatment plan for your patients. Then you will move into the phase 1 treatment. But first, if some teeth is not desirable for the removable partial dentures design, those teeth might need to be extracted. Also, if patient have some soft tissue or hard tissues, discrepancies may affect your dentures design. They also need to do some surgical preparations. So what kind of soft tissue or hard tissues discrepancy can be affected? The first is the tuberosity undercut. When patient lost a tooth on the maxilla, then the posterior teeth area have tuberosities that might enlarge, and those bony exostosis or undercut probably will affect your prosthesis settings that will cause the complications. So you have to ask for the surgical removal. When patients have maxillary TORIs, that it might also affect your major connective design. So we might also want to ask for the surgical removal. However, some maxillary tori may be able to left alone, depends on its size and proposed design of a major connectors. So we will discuss this later when we evolve into the major connector topic. The tori is not just only happen on the maxilla, it also can be happen on the mandible. However, due to our anatomy limitations, most of the mandibular tori of this size, like you see on the pictures, are recommended for surgical removal because it will cause you have a difficulty to design a framework of a partial prosthesis. So what's the reason why we say on the mandible most of the cases will need to have a surgical removal? Because the tissue impingement of this thin mucosal lining can happen and will due to the overseeding of a major connector of a mandibular partial prosthesis. It will cause patient have discomfort and eventually have a sore spot. So if you have a mandibular tori of the patients, then you might highly suggest that to remove that. And sometimes after extractions, we will see some buccal bony exostosis. Those buccal exostosis may be able to maintain if it's not in the area of prosthesis involvement. However, if it really involves into your design, that surgical removal or what we call a veiloplasty is required. That's why in the first beginning I said you should have your preliminary surveying and RPD framework design to be approved, so you will know if those bony exostosis will need or not need to be removed, followed by your design. Also, some patients lost tooth for a long time, so existing tooth might tilt. Those tilting tooth sometimes are suitable as abutment by the orthodontic upwritings. However, some teeth might not able to use that, so you have to do also orthodontic consultations if you want to upright those tilted tooths. And when we talk to the rest and resties topic, we will also talk about maybe you have some options design can suitable for the tilted tooth without do the orthodontic movement. The last one in the phase 1 treatment is the disease control. So when patients have a periodontal disease, you may need to finish your periodontal therapies. If the soft tissue is irritating by the existing partial dentures or prosthesis, you will need to do a tissue conditioning. Also, some patients might need to extract the teeth and wait the tissue healed during this phase, healing phases. You might also need an interim or temporary removable partial dentures. Also, some abutment tools may need some restorations. After you finish the phase 1 treatment, then all the teeth and the soft tissue and hard tissue intraorally should be in a good health condition. After that, then you will start the phase 2 treatment. It's the definitive treatment. So you might also need to do some crown or bridge, or maybe patient will need the implants combined with the removable partial dentures, then you will start it. And finally, you will do the final mouse preparations to accommodate your RPD design. So in summary, the procedure to do a removable partial dentures in the first beginning is to do examinations to get all the chief complaints, past medical dental history, do all intraoral, extraoral examinations. Also remember to evaluate the patient's psychological factors, then you'll come out your diagnosis. When you have your diagnosis, then you also need to have the diagnostic cast mounting and then to evaluate. When you finish those, then you will finish your preliminary surveying and to come out your RPD framework design. After you got those design be finished, then you will know how you need to treat those soft and hard tissue intraorally. So that's a phase 1 to finish the disease control. After you control all the disease and make sure the oral environment is health, then you will move to the phase 2 treatment to do the definitive RPD. That will be the whole procedures which you need to follow in all patients' treatments. Okay, so let's talk about the candidate classifications now. So what's the candidate classifications comes out? So the candidate classification systems is formed by Dr. Edward Kennedy in 1925. Because we need to have some general term in which we can use to discuss the cases with our colleagues. So that's why we need to use this candidate classification to determine or define the edentulous areas. And when Dr. Kennedy developed this system, he comes out 4 different classifications. And he used the frequency of occurrence by his experience. So he said the class 1 is most frequently encountered in his practice, and the class 4 is the least frequently encountered. So what's the class 1 classifications? The class 1 classification means that patients have bilateral edentulous area located posterior to the remaining natural teeth. However, if those edentulous area located posterior to the remaining natural teeth just be unilateral, that would be the class 2. And take a look. So when we say those edentulous area located posterior to the remaining natural teeth, means that on those edentulous area there's no teeth in the back. So class 1 and class 2, there's no teeth in the back. However, if we have edentulous area and with the natural teeth both anterior and posterior to that area, then we will call class 3. If those single edentulous area located to the anterior to the remaining natural teeth and cross the midline, then we will call class 4. So class 3 and class 4 just depends on if those edentulous area will cross the midline. If it crosses the midline, it will be called class 4. If it's not, that will be called class 3. However, when we look at some complicated cases like what you saw here on the pictures, so you remember that you said, okay, I just learned, so both distal edentulous area we called class 1. However, I still see the other 2 edentulous area is between the tooths. That's class 3. So how should I call it? Should I call it class 1 and class 3? Or should I call it class 4 to add it all together? Or should I just call it class 1 or class 3? So that's a problem. So candidate classification is not able to available for all the cases right now. So that's why Dr. APPLEGATE'S developed the other 8 rules, try to use or try to modify the first candidate classifications. And we will explain this in the following. The first important thing is to know the Rule 5. The Rule 5 says the most posterior edentulous areas always determines the classifications. So for example, remember the case I showed you. These complicated cases actually have 4 edentulous area. So followed by the Rule 5, we use the most posterior edentulous areas to determine the classification. So that will be the yellow one. So as you can see, this will be called class 1 first. This will not be called class 3 because we use the most posterior edentulous area to determine the classification. However, how about those 2 edentulous areas in the front? How can we call that? So Dr. Applegate said in the Rule 6, those edentulous areas other than those that determine the classification are referred to as modification and designated by their numbers. He also said in Rule 7, The extent of modification is not considered, only the number of additional edentulous area, what it means. So, we already know those two yellow edentulous area already be determined the class 1 classification. And we also left two edentulous area in the front. So, we have two area haven't been used. So those two will be called modifications. And when we say what type of a classification of these cases, then we just count for the numbers of the area. We are not account for how many teeth it lost. So in these cases, we'll call class 1 modification 2. After we know how to determine or define the modifications, let's look at the other APPLEGATE'S rules. The rule 1 said the classification should follow rather than precede any instructions of a tooth that might alter the original classification. For example, when you look at this graph, you can see the tooth number 15 and 16 is assisted. However, if after your diagnosis and you found out those 15 and 16 tooth is not available, need to be extracted, then when you say the classifications, then you should use the extractions conditions to determine. So you'll call class 2 because you will have unilateral edentulous area posterior to the natural teeth. However, if those two teeth still available to save it, then this will be called class 3. So you can see the different case scenario will give you the different classifications. So when you being asked for the classification, you should ask first. So what's the case scenario? If you are not able to be given the case scenario, you are not able to give the proper or correct classification. The second rule is talk about if a third molar is missing and is not to be replaced, it is not considered in the classification. For example, in here, patient lost or missing the tooth number 16 and you are not restored, then actually these cases will just be called class 3, depends on the right side's missing area. The rule 3 is an exception. So what if we want to restore the class 3? Or what if we have a third molar present and will be used as a abutment? Then you have to consider the third molar relationship into your classification. So for example, you take a look for those two different grafts. They all have the same tooth. However, on the left side, we were going to use the third molar as abutment, means that we will put a clasp on that. However, on the right side, we will not use the third molar on the tooth as abutment. So you will be given the different classification on the left side because you were going to use the third molar. So that's a edentulous area between anterior and posterior teeth. So that's a class 3. And you have one modification area. That's why we call class 3 modification 1. However, on the right side, because we are not going to use the tooth number 16 as abutment tooth, so the edentulous area actually will become the edentulous area posterior to the natural teeth, and it's a unilateral posterior edentulous area. So that's class 2. And you also have one modification area on the other side. So that's what we call class 2 modification 1. And how about if we missing the second molar? So the rule 4 said if a second molar is missing and you are not ready to replace it, then you also will not be considered into the classifications. So look at here. If we are not restore the second molar, the tooth number 15, actually edentulous area just happened on the right side. So that's class 3. However, if you are saying that I'm going to restore tooth number 15, what happens? Then it becomes one edentulous area is posterior to the tooth unilaterally. So that's a class 2. So you become class 2 modification 1. So let me remind you again. When you see the same missing tooth, however, when you be given the different case scenario, you will give different classification. So remember, check the scenario first and to determine what the classification is correct. And the rule number 8 is talk about there will be no modification area could be included in class 4 arch. Means that all the edentulous area that lie posterior to the single bilateral area crossing the midline will instead determine the classification. That's from the rule 5. The rule 5 said the most posterior edentulous area always determine the classification. So when you see or when you determine the class 4 classification, it's never ever able to have a modification. So there will be no way you call a case the class 4 modification 1 or modification 2. The class 4 will no longer have modification. If you have a class 4 also want to call it modification, you might think about that's a posterior edentulous area, and you should use that to determine your classification, not the front area. Okay, so that's quickly to do your self-exam. So when you look at this case now, and you say, okay, I see that all the molar area is gone, and I'm gonna use a removable partial denture to restore it. So what we call this, we have a bilateral edentulous area. Both are posterior to the natural teeth. So this is class 1. In here, in these cases, if I said this, we were not gonna restore the third molar, and we will use tooth number 2 and 15 as our abutment, what's the classification it would be? So actually, you will see the edentulous area will all between the natural teeth. So you know that would be called class 3. And you just need to use single edentulous area between the tooth to determine class 3. So you will left 2 other modifications area. That's why we call classification 3 modification 2. But what if I told you I was gonna not restore the third molar? I also won't be able to use tooth number 2 and 15 as abutment because of poor periodontal health. So what this will become? So this will become 2 edentulous area posterior to the natural teeth. That will be class 1. And then you have one tiny space haven't been used to determine the classification. So that will be class 1, modification 1. And in the different cases, so if you saw here, if you be told that this case will not be restored at the third molar, and we will use 15 as one abutment tooth. However, the tooth number 4 and 5 need to be extracted because those two structure is efficient. Then what's the classification it will be called? So think about that. On the right side, next to the canine, there's no teeth, right? So the posterior edentulous area next to posterior to the natural teeth, that's class 2 because that's unilaterally. However, we still have 2 edentulous area between the tooth, so that we call class 2 modification 2. However, if this case I told you we were not going to restore the third molar, we will still use number 15 as abutment. However, now 4 and 5 and 13 need to be extracted because of insufficient tooth structures. What it become? They'll become class 2 modification 1 because eventually we will remove tooth number 13. So we will just left one edentulous area between the tooths. So remember, if you need to extract any teeth followed by your plan, then you have to use the condition after extraction to determine the classifications.